that. And speak at your own risk. It is recorded. Also, if you could please mute your line if you're not speaking to eliminate some background noise, but please don't mute my FSSA line. That makes us log back in and it's not fun for anybody. So if you could please mute your own line and not mine, that would be fantastic. Per previous meetings, I will defer to Dr. Shaw to drive the agenda as we move forward. If you're wishing to provide public comment, when we get to that point, you can either put public comment in the chat box. We have a sign up in here, as well as raise your hand or whatever at that time when we get to that. And then anything that we need a vote for, we will, after we get the motion in the second, I will do the roll call voting as we've done in the past. You can do aye, nay, or abstain. And I think that's all of the announcements that I have before we get started. So Dr. Shaw, I will lend it over to you for the call to order.
All right. So I will call the February 2nd, 2024 meeting, the Therapeutics Committee meeting to order. The first item on the agenda are comments from OMPP. Nothing this morning. Thank you. Okay. Thank you. The next item on the agenda is the approval of the memoranda from the November 3rd, 2023 meeting. The memoranda has been previously provided by Optum and distributed. Could I have a motion to approve the? Okay. Second?
Second, Dr. Marshall.
Okay. Any discussion, edits, revisions to the memoranda? Okay. See no comments? All in favor?
I got to do my roll call.
Oh, yes.
Sorry. Dr. Shaw.
Aye.
Dr. Marshall.
Aye.
Mr. Musial.
Aye.
Dr. Negandang.
Aye.
Dr. Patel.
Aye.
And Dr. Weber.
Aye.
All right, we have all ayes, so that will carry. Thank you.
Okay. Next item of the agenda is the election of the officers for the calendar year 2024. Could I solicit nominations for the role of chair and vice chair?
I'm only looking at you, Brian, because you're the only person in here. It's harder for me to like stare down the people nominating.
So moved. This Dr. Marshall, so moved.
Who are you moving?
The only person you can see.
Well, Dr. Shaw's here too. I guess I could stare down Dr. Shaw too.
Dr. Shaw, I move Dr. Shaw. Thank you.
I appreciate the nominations.
You need a second. I'll second. For Dr. Shaw.
Okay. Could I nominate Dr. Weber for role of vice chair?
Second, Dr. Marshall.
All right.
Thank you. I appreciate the nomination.
Any further nominations? All right. All in favor of Dr. Shaw? Oh, I'm sorry. Force of many years of habit.
Dr. Shaw.
Aye.
Dr. Marshall.
Aye.
Mr. Musial.
Aye.
Dr. Negandang.
Aye.
Dr. Patel.
Aye.
And Dr. Weber.
Aye.
All right, we have all ayes, so that motion will carry. Congratulations, Dr. Shaw and Dr. Weber. Thank you.
Thank you. All right. The agenda moves over to Optum in terms of presentation of the preferred drug list categories to be reviewed.
Let's get us going. So for the respiratory recommendations, we have no recommended changes in the classes listed here. Just to do a quick check, if you, Dr. Weber or Dr. Negandang, if you want to give me a thumbs up, you can see the screen on your end, right? Perfect, thank you. For the beta adrenergics and corticosteroids, the recommendations are for Advair 230 per 21 to maintain its current status but remove its step therapy requirement. For the Air Duo Respiclick to move to preferred and maintain its current quantity limit of 1 inhaler per month. And then for the generic Advair Discus 500 per 50, the fluticasone salmeterol maintain its current status and remove its step therapy requirement. And just as an FYI for both that one and the Advair, the 230 that we're removing the step therapy on, we're just doing that because I think it's a historical step therapy to have them trial the lower or medium doses prior, and that was probably related to cost. We don't do that on any of the other therapies or any of the other strengths. So just to be consistent throughout about the other inhalers, we are removing that step therapies and just kind of let people progress as they progress. For the Airsupra, which is a new albuterol budesonide product, adding to non-preferred with an age limit of 18 years of age or older and 2 canisters per 30 days. For the nasal antihistamines, nasal anti-inflammatory steroids, azolastine fluticasone moved to non-preferred and add to the generic medically necessary PA, and then its brand Dymista moved to preferred and the brand preferred list, which would be effective on 4/1. For the respiratory and allergy biologics, Dupixent has a new indication or update to their indication. So maintaining its current status, but updating its age limit for the eosinophilic esophagitis criteria for 1 year of age or older and weighing at least 15 kilos. And that concludes the respiratory recommendations. For the anti-infectives, we have no recommended changes in the classes listed here. For the hepatitis C agents, we wanted to update the PA criteria for anybody who has had a treatment history that we can see, like a paid claim, or they tell us they've had a treatment history, to collect recent labs and genotype within the past 6 months. This has happened for a couple of reasons. We've had some situations where we find a claim that somebody's been treated before, and maybe the other prescriber doesn't know now that they've been treated. And maybe, or it's been a long period of time since we've seen labs. We do know that some people spontaneously clear, so we want to make sure that they haven't done that. We also want to make sure that they have the same genotype, that if they did take treatment before and somehow, something changed, or so we're just trying to make sure we've got everything that we need there when we're looking at that. For the PEG intron, I'm removing it from the SUPDL as it's no longer manufactured and CMS termed. For the macrolides, for the EES granules, maintaining its current step therapy, but just clarifying, or maintaining its current status, but clarifying its step therapy. So must have trialed and failed the erythromycin ethylsuccinate suspension in the past 90 days, or the member must be under 12 years of age or unable to swallow the tablets or capsules, and the prescriber has provided medical rationale for why they can't use the EES granules. So really this is adding the 90 days in there, just because somebody could theoretically try that product again and maybe it would work at that time, or maybe they're able to swallow at this point and we, they've gotten older and we haven't captured that. So just kind of capturing that look back. For the ophthalmic antibiotics, Moxiza is no longer manufactured in CMS terms, so removing that, but there is still the moxifloxacin available. For the otic antibiotics, polymyxin S is no longer manufactured in CMS terms, so removing that from the SUPDL. And the vaginal antimicrobials, Zacchiato, adding to non-preferred and creating in the antibacterial subcategory. And that concludes the anti-infectives. All right, for the cardiovascular agents, no recommended changes in the classes listed here. For the ACE inhibitors, and you'll see these through several classes as we move through the cardiovascular agents, we're updating the step therapy around the age of use and being able to swallow tablets. So for Cubrellis, maintaining its current status, but updating step therapy to must be 6 years of age and older and less than 12 or unable to swallow the tablets. In the angiotensin receptor blockers for the valsartan solution, adding to non-preferred and having a step therapy, it must be 6 years of age and older and less than 12 years of age or unable to swallow tablets. For the beta adrenergic blockers, we have the hemangiol solution maintaining its current status, updating its step therapy to must be 5 weeks of age or older and less than or equal to 1 year of age for its use. In the calcium channel blockers, several suspension solutions for amlodipine and nimodipine. So Catersia must be 6 years of age or older and less than 12 years of age or unable to swallow tablets and a previous trial and failure of Norleakva or medical rationale for use. And Catersia would have its status maintained. Norleekva maintaining its status, but updating its step therapy to must be 6 years of age or older, or less than 12 or unable to swallow tablets. And then Nymalized solution maintaining its current status, and its step therapy would be must be 18 years of age or older and unable to swallow tablets. That concludes the cardiovascular. No recommended changes in lipotropics this time. I don't know that I've ever said that, but I'm saying it today. And the anti-migraine agents. For elatriptan, maintaining its current status and quantity limit, but adding to the generic medically necessary PA, and then its brand Relpax, maintaining its current status and current quantity limit, but adding it to the brand preferred list. The sumatriptan nasal spray moving to preferred and maintaining its current quantity limit, and the zolmitriptan nasal spray moving to non-preferred, maintaining its current quantity limit, but then allowing those who have a history within the past 90 days to continue use. I think we flipped those not all that long ago, a year or two ago, and we're flipping them back. For the electrolyte depleters, for the phosphonol chews, they are no longer manufactured in CMS terms, so removing them from the SUPDL and the brand preferred list. And then it's generic, the lanthanum carbonate chew, maintaining its current status, but then removing it from the generic medically necessary PA since the brand's not available. Foslera is also no longer manufactured in CMS terms, so we're removing that from the SUPDL. And then we have a new product, Zefosa, which is a phosphate. It's not a phosphate binder, but works in a similar fashion. And so adding to non-preferred and with step therapy that must have tried and failed preferred phosphate binders or submit medical rationale for use over all preferred phosphate binders. It is considered kind of a second line or third line, kind of a refractory product. And that concludes the electrolyte depleters. For the multiple sclerosis agents, Tisabri maintaining its current status but updating its Crohn's disease indication to allow for Rinvoq trial to be considered for a step therapy requirement. So their Rinvoq just recently got the indication, and so just kind of allowing that to cross over. If at some point, we've kind of got a few agents now that have some kind of cross between MS and into the TIMI space, and we'll kind of continue to monitor that to see if we need to make any adjustments there if we get new indications. And that concludes MS. And then for the targeted immunomodulators, a lot of biosimilars. It just like exploded for the adalimumab biosimilars. So we've got Abrelata adding to non-preferred and the non-preferred two-step Silenoth criteria. The adalimumab AACF adding to non-preferred and the non-preferred two-step criteria. Same thing for the adalimumab ADBM. And then for the adalimumab FKJP and Hadlima and Humira, maintaining their current statuses, but then for the Crohn's disease indication, removing the infliximab trial from the approval criteria. Adbry, maintaining its current status, but updating the age limit to 12 years of age or older for moderate to severe atopic dermatitis. Bimzelx, which is a new product, adding to non-preferred and the non-preferred two-step criteria. Cosentyx, maintaining its current status. It just recently received indication for hidradenitis suppurativa, so adding that as an indication with a step through a preferred adalimumab product or agent or rationale for why they need to use Cosentyx over the preferred adalimumab agents. Adakio, maintaining its current status and adding non-infectious uveitis indication to their approval criteria, so they were biosimilar that previously didn't have that just received it. Omvo adding to non-preferred and the non-preferred two-step criteria. And then Alaris recently received a new indication, so maintaining its current status, but it has an indication now for a treatment of symptomatic gout flare in whom patients that colchicine, corticosteroids, and or NSAIDs are contraindicated or have provided some inadequate response in the past. Velsipity, adding to non-preferred and the non-preferred two-step Silenoth criteria, and then including a step through Zeposia and one other targeted immunomodulator agent. Xeljanz solution, maintaining its current status, but then updating its step therapy around swallowing. So member is 2 years of age or older and weighing 10 kilograms or more and less than 18 years of age and weighing less than 40 kilos, or the provider has submitted some documentation supporting an inability to swallow the tablet formulation. And then another adalimumab biosimilar, Euflema, is maintaining its current status, but it also received the indication for non-infectious uveitis to add to their approval criteria. And that concludes the targeted immunomodulators and our updates. Which then takes us to any questions before we move on to new business and discuss some of the reporting. All right, any other new business before I go through some of our opioid reporting that we need to discuss today?
The published agenda included injectable hypoglycemic insulin. That's just not being covered today.
We did end up, so we were going to cover them off cycle for review this time because of the AMP cap removal and the change in the pricing and their adjustment of price. We actually don't have some of that data yet for their adjustments, and we won't have it until May, is that right? So we will be bringing it to you at a later time to discuss when we have more information on their actual pricing changes.
So I think the ADA doesn't usually refer to the classes as hypoglycemics, but probably anti-hyperglycemics.
Okay.
So maybe
we can bring that maybe as a recommendation next time to update the class name.
Just so that we can, because we don't want to really promote hypoglycemics.
Sure, that's fair. Anti-hypoglycemics. Okay.
And then the only other idea that I might offer in terms of just discussion under the new business section is, I'm not intending to sort of insert anything in terms of a discussion between OFBP and Optum, but at the VA, we're seeing a lot of uptake in finerenone, Corindia. So I don't know if we want to think about starting to cover aldosterone antagonists.
Okay,
But maybe
we do have a
discussion.
PA in place for those products. We have step therapy.
Okay. I
For that
was looking at
already.
the website last night. I couldn't find it.
It's under,
Non-SUPDL, PA, and step therapy.
Okay.
yeah, and I can,
Which you probably don't look at very much because it has nothing to do with PDL, so. But if we're at a point where we need to consider moving that class into the PDL at some point, not right now, maybe, but.
Sure.
We can do
I
that.
can also pull it up for you though, just so you can, so we cleverly disguise it on the website because that's what we like to do. We have it under the non. I was just gonna put it up so we can see it on the.
Because I had read that KDIGO came up with new recommendations regarding mineral receptor antagonists.
So anything that we have PA on or step therapy that's not on the PDL that we don't call out in another class where it's just kind of like a generic thing, we put it under this non-SUPDL agents PA and criteria. So if you're ever like, where is this criteria at? That's what we put it under. So we've got just kind of what I call like, it's almost like a hodgepodge in here of just drug, like singular drugs where we're, you know, trying to cover something. And so for Corindia, sure you get it. Yeah, there's the criteria that we have there. So the diagnosis of chronic kidney disease in type 2, members 18 years of age or older, and then looking for trial and failure of SGLT2 or some reason why they would need to utilize that agent, or they have a history.
Okay. Yeah.
Just for your reference, but we're certainly happy to bring that back and look at.
Yeah, because I think the new KDIGO has different guidelines.
Okay. We'll discuss that and see about adding that in.
Okay.
Yep. All right. Any other new business before opioid reporting? All right. So this is data from December. We did have a slight decrease from November, which was a little bit up, and not surprising in December with the holiday week and prescribers being out. We do tend to see that a little bit anyway in December. For the utilizers under 18, their average day supply has actually kind of continued to go down a little bit. We're at like 4.3. I think when we started, they were around 5. So they kind of continue to decrease their average day supply, which is good. You can see the average MME over here in the table and those that are PA exempt, but I do think the graphs are a little bit more helpful. So I'm going to switch to that. So this is showing all of those that are 90 and above. Just a reminder, most of our patients are in the less than 90, but we do have, kind of some small numbers here, obviously, of who's in the 90 and above range. When we look at just kind of overall our trend, I mean, we're kind of steadying out a little bit in November and December, but we've kind of still seen that slight increase overall. And we are still evaluating, Dr. Shaw, I know you talked about the ER physician, so we're still kind of looking at that and see what we can see. You can see, the new utilizers here in the cranberryish color did decrease a little bit from November and October, as well as the current utilizers under 18. So kind of a steady out between November and December. January, I'm kind of expecting to probably see change a little bit from that, just because November, December do tend to be a little bit lighter months, depending on what's going on because of the holidays. Here's our less than 90 trending. So you can see just a slight decrease in the less than 90 there. I've got no real rationale for that at this point. I don't know that I necessarily think people moved above 90. It may be people that just moved off therapy. I just don't have great insight. And again, we have smaller numbers, so it's just kind of hard to really know what was happening. But overall, they were kind of trending upward. In the 90 and above, you can see that we do have kind of some trending upward where we would expect in the 250 to 500. It was kind of going on the upwards trend and then has kind of come down a little bit. And then we've seen kind of again, 750 and the 500 to 750 go down. We're at what are we at, 555? 525. I keep thinking 475 because that's what we're putting in next. So 475 goes in April, but we're at 525 right now for MME. So slowly but surely we're making our way down, and kind of where we would expect to see things kind of go up, they are. But again, these are very small numbers, so changing a couple of people really can skew what we're looking at. But nothing really surprising in what I'm seeing in kind of the data here. Any questions or comments on any of that? All right.
Amanda, quick question. Do those utilization numbers include buprenorphine as well?
No, they do not.
No. Okay.
Well, unless it's buprenorphine specifically only for pain, so like Belbuca and Butrans.
Sure.
But as far as MOUD, no, it does not include those. We have just anecdotally, so you know, since we present this data, we have seen a slight increase in MOUD utilization and prescribers since the XDEA waiver has been removed, which is good. So we're seeing a little bit of increased utilization there in the fee-for-service benefit. Any other questions or comments? All right. That will take us to the public comment portion. We will start with the in-person folks first. So Dr. Shaw has that list, so he will start with that.
So we would, consistent with past actions of the Therapeutics Committee, we will invite any practitioners in the room to want to speak first. I don't see any on the sign-up list, but okay. First person signed up is Neelish Nadkarni with AbbVie.
Good morning. Can you guys hear me? Okay. All right, great. All right, good morning, everyone. My name is Neelish Nadkarni, pharmacist and medical outcomes and science liaison for AbbVie. Thank you to all of you for the opportunity to speak here in person today regarding atogepant, brand name Qulipta, for which I'm going to refer to as ADO. ADO is an oral, once daily CGRP receptor antagonist indicated for the preventive treatment of migraine in adults. It has an approximate peak plasma concentration of 1 to 2 hours, half-life of 11 hours, and clearance of drug in 3 days. ADO was evaluated in 2 separate 12-week phase 3 multi-center randomized double-blind placebo-controlled parallel group clinical trials for both episodic and chronic migraine. From an efficacy standpoint, the primary endpoint of change from baseline in mean monthly migraine days across 12 weeks was compared to placebo, and that was met with all 3 doses for episodic migraine and the 60 mg dose for chronic migraine. ADO is the only CGRP product that met all 6 key secondary endpoints as compared to placebo for the 30 mg and 60 mg doses for episodic migraine and 60 milligrams for chronic migraine, including 3 patient-reported outcomes. Now, all study doses of ADO significantly reduced mean monthly headache days and mean monthly acute medication use days. 55% of episodic migraine patients and 41% of chronic migraine patients experienced at least a 50% reduction of migraine days over 12 weeks. Now, health outcomes data have demonstrated that ADO has the lowest number needed to treat when compared to all approved CGRP gepants and monoclonal antibodies used for the prevention of migraine, resulting in cost savings. Now, from a safety perspective, there's one contraindication and warning about hypersensitivity reactions. Most frequent ADRs reported in the phase 3 trial were constipation, nausea, and fatigue somnolence. Discontinuation rates due to these 3 adverse reactions were less than 1%. In summary, along with its oral once daily preventive dosing, Qulipta's overall efficacy and safety are demonstrated in reducing migraine days and acute medication use days. So, given the data I covered here with you and the potential cost savings of Qulipta, we respectfully request the committee to consider removing a MAB step prior to receiving Qulipta. This was an abbreviated review of Qulipta. Please refer to the PI for more information. Thank you for your time.
Sorry, I don't know why it's fussing. All right, next one.
Did anybody have any
So
questions?
it is a preferred agent. Is there a particular aspect of the step edit that you wish to?
Yeah, so, correct me if I'm wrong, but on the criteria, it's indicated as, I believe, failing each MAB before beginning oral gepant, togepant. So we're just respectfully requesting from the committee to just consider having failed 1 versus all or 1 versus 2, given the data that we covered and the safety and the fact that it has flexibility with 3 doses on episodic and 1 dose on chronic, and a short half-life, lowest NNT, and just full spectrum, not only just episodic, but also more severe chronic.
Thank you.
Thank you.
Okay. Next person is Rick Zamalis with BMS.
Very good. That was pretty good. Good morning. I'm Rick Smilas. I'm a health economics and outcomes research scientist for Bristol Myers Squibb. I'm also a registered pharmacist in Indiana. I'm pleased to speak today on behalf of SOTIC2 for adult patients with moderate to severe plaque psoriasis who are candidates for systemic therapy or phototherapy. Please refer to www.sotic2.com for complete prescribing information. SOTIC2, or deucravacitinib, is the first and only once daily selective tyrosine kinase inhibitor with a distinct mechanism of action. SOTIC2 demonstrated superior efficacy and skin clearance to placebo and Otezla in 2 pivotal clinical trials. They are multi-center randomized double-blind placebo and active comparator controlled trials to evaluate the safety and efficacy of SOTIC2 6 milligrams daily versus placebo at week 16 and versus Otezla 30 milligrams twice daily through week 52. The co-primary endpoints were met for PASI 75 and SPGA 01 versus placebo in both studies. With respect to secondary analysis, additional statistical significance was noted achieved for PASI 75 versus Otezla at week 16 and 24. The proportion of patients achieving a scalp-specific physician's global assessment score of 0 or 1 was significantly higher for SOTIC2 versus Otezla at week 16. Finally, demonstrating durability, the proportion of patients achieving a PASI 75 at week 24 that maintained PASI 75 at week 52 while continuing SOTIC2 for poetic PSO1 and poetic PSO2 were 82% and 80% respectively. In terms of safety, serious infections through week 16 were reported in 5 patients treated with SOTIC2, 2 with a placebo. Through week 52, the most common serious infections reported were pneumonia and COVID-19. though most patients who experienced COVID-19 related serious adverse events had known or potential risk factors for severe illness from COVID-19. Discontinuation rates due to all adverse reactions at week 16 were 2.4% with Sotec-2, 5.2% with apremilast, and 3.8% with placebo. Please refer to the full prescribing information and complete safety profile. We're pretty excited about Sotec-2 having demonstrated efficacy, safety, and tolerability versus an active comparator. I sincerely appreciate your time and consideration to add Sotec-2 to the PDL and welcome any questions. Thank you. Boy, I hit the post, didn't I?
You were a little over. I tried to stop it.
Oh, I'm sorry. Thank you.
So it didn't beep at us incessantly.
Any questions?
I don't see any. Thank you.
Thank you.
All right, we do have one public comment listed online right now. If you are online and you wish to provide public comment and you haven't signed up yet, you can sign up in the chat or you can raise your hand and I will get to you in the order that they are raised. So the first that I have up is Melinda Turkington with UCB on BIMZELX.
Great. Thank you. Good morning. I'm Melinda Turkington, a medical outcomes liaison with UCB. I'd like to update you on the clinical information of bimekizumab BKZX, brand name BIMZELX, humanized interleukin IL-17A and F antagonist. BIMZELX is the first and only FDA-approved humanized interleukin IL-17A and F antagonist indicated for the treatment of moderate to severe plaque psoriasis in adults who are candidates for systemic therapy or phototherapy. BIMZELX is available as a prefilled syringe and autoinjector for self-injection or administration by a healthcare provider. It's dosed at 400 milligrams every 4 weeks for 16 weeks, with the option of switching to 400 milligrams every 8 weeks after those 16 weeks for patients weighing less than 120 kilograms. 3 multi-center randomized double-blind studies enrolled 1,480 subjects 18 years of age and older with moderate to severe plaque psoriasis. At week 16, 85 to 91% of patients achieved PASI 90, 84 to 93% of patients achieved an IGA of 0 to 1 response. Additionally, 59 to 68% of patients achieved a PASI 100 or completely clear skin. Most common adverse events of greater than 1% were upper respiratory tract infection, oral candidiasis, headache, injection site reaction, tinea, gastroenteritis, herpes simplex infections, acne folliculitis, and other candida infections and fatigue. BIMZELX may increase the risk of suicidal ideation and behavior, but a causal association between treatment has not been identified. BIMZELX may increase the risk of infection. Please evaluate patients for tuberculosis. Test liver enzymes, alkaline phosphatase, and bilirubin at baseline, periodically during treatment with BIMZELX, and according to routine patient management. Cases of inflammatory bowel disease have been reported in patients treated with IL-17 inhibitors. Please refer to our prescribing information for the full safety and efficacy profile. And thank you for your time.
Any questions? My apologies for pronouncing your drug name wrong. I feel like it should have an extra E in there to be BIMZELX, but I will correct appropriately. Thank you. Any other public comment? I don't see anything in the chat box right now. Any other? No hands are raised at the moment, I don't think. All right. That takes us to other business then. Any other business?
I don't believe there is.
All right, then I think that takes us to adjournment. We have until 10 for the next session. And so those who are in the room, if you can just make sure you've taken your things and closed up before then so we can get settled and get ready, that would be great. And the next public session will start at 11. If for some reason we're late, which I don't anticipate we will be, but if we are, we will join the meeting online as soon as we can and then let folks into the room at that point as well. But I would anticipate we'll be on time at 11. Thank you. And everybody on the committee should have received the closed session invite for the next session. We will see you all around 10. Thank you.
Just exploded on me.
What happened to you? Oh, no. There's no paper towel in the bathroom.
We don't have paper towels here. Yeah. We don't, they won't let us have paper towels.
No, they're very-